Hello, everyone, and welcome. My name is Martha Macaluso, and I'm a myofunctional therapist and co-founder at Manhattan Myofunctional Therapy, LLC. And today I'm honored to have Mr. Patrick McKeown again to join us for part 2 on the importance of nasal breathing and sleep-disordered breathing. Patrick is a world leader in butycal breathing re-education and has published various books in butycal breathing, with his most recent publication titled The Oxygen Advantage, which is this wonderful book right here that gives you a lot of information about breathing re-education as well. So don't forget to check out all his books. He does have quite a number of books, and they're all very informative and very helpful. So Patrick, I'm handing it over to you.
Thanks very much, Marta, and thanks so much for the introduction. What I want to do this morning is just to go through a few slides and looking at the importance of a gas called nitric oxide. And nitric oxide, it's received quite a lot of attention in the last, couple of decades. And before that, it usually received bad press because nitric oxide is one of these gases which is implicated in causing pollution. And scientists had a hard time believing, how could a gas that's so toxic outside of the human body be actually beneficial inside of it? And it's really the work that it does throughout the body is amazing. The journal Science said in 1992 it's molecule of the year. It's been referred to as the mighty molecule, and it unites all the major disciplines of medicine. And one of the functions of nitric oxide, or one of the functions of the nose, is that when we nasal breathe, we carry nitric oxide from the nasal cavity into the lower airways, and there it helps to open up the airways. It sterilizes the incoming air. It also assists in ventilation perfusion. And it's interesting that researchers have seen that there's a role in nitric oxide in obstructive sleep apnea. And I'm quoting here that they're inseparable. And that obstructive sleep apnea could be described as the intermittent failure to transport the full complement of nasal nitric oxide to the lung with each breath. In other words, that nitric oxide may be playing a role in the signaling of the upper airways to remain open, the dilating force of the upper airways. Because we remember from part 1, we were talking about obstructive sleep apnea. It's a cessation of breathing. It's when we stop breathing during sleep. And it's when the negative pressure caused during inspiration is greater than the dilating force of the airways to remain open. So you can imagine that as you're sucking air into your lungs, and as you're bringing that air into your lungs, the upper airways, which is basically your pharynx, the oropharynx, the nasal pharynx, that's prone to collapse. So the harder we breathe, the more prone to collapse it is. And if we breathe through the nose, it may be that nitric oxide is sending the signals to the dilating airways for the muscles to work harder to remain open. And nitric oxide, as I said earlier on, one of the roles is with ventilation perfusion. In other words, as human beings, because we're upright, the greatest concentration of blood in the lungs is in the lower parts of the lungs, basically due to gravity. But if we mouth breathe for any reason, we often bring more air into the upper part. So there's a mismatch going on. If we're taking the air into the upper part and the blood flow and the blood concentration is in the lower, it's an issue. So nitric oxide is wonderful in that when you breathe through your nose, you carry nitric oxide into the lungs, and nitric oxide brings the blood from the lower lobes up to the upper. So it's utilized by the conducting pathways to control the unequal inspiratory battle. And I think this is a great one. You can imagine that there is a little bit of a battle going on. The pharyngeal dilators, the airways want to remain open, and the battle is with the closing negative pressures induced by the thoracic musculature due to breathing. And in simple terms, that's really what obstructive sleep apnea is, of course. Mm-hmm. Nitric oxide, if we breathe through the nose, it's 50 to 200 parts per billion. It's transported to the lungs with every nasal inhalation, compared to 10 parts per billion during oral breathing. So there's really no comparison. The mouth is not really harnessing the capability of nitric oxide. So the nose, it's a really important function, breathing through it to capture that nitric oxide. And nitric oxide is always continuously being released into the nasal cavity. So we've got 4 paranasal sinuses, and it's being released from the paranasal sinuses continuously into the nasal cavity. And when we breathe soft and slow, we've got a higher concentration of nitric oxide coming into the lungs, as opposed to breathing hard and fast. Since nitric oxide is continuously released into the nasal airways, the concentration will be dependent on the flow rate by which the sample is aspirated. Thus, nasal nitric oxide concentrations are higher at lower flow rates. And what this is pointing to is the importance of gentle, soft breathing. You know, when you're breathing gently and breathing softly, we've got a higher concentration of nitric oxide coming from the nasal cavity into the lungs, and there it's able to perform its work. And the Nobel Prize in Medicine and Physiology was awarded for the discovery of nitric oxide as a signaling molecule in the cardiovascular system. And this gas is vasodilator, has a half-life of 2 to 30 seconds. So this is a 2015 paper that's referenced. Now, I have since seen that it can last from between 1 and 6 seconds. So there seems to be a little bit inconsistency exactly how long does it last in the body for. But bearing in mind that it just takes 3/4 of a second for gas transfer to take place from the lungs to the blood, it still should be able to go from the nasal cavity into the lungs and pass into the blood relatively quickly. So the biological significance of nasal breathing, which improves peripheral oxygenation by 5 to 15% in healthy volunteers compared with oral breathing. And this is probably based as well on the benefit of nitric oxide. And as we'll see in later sections that we're looking at, lung function too can play a role in OSA, in obstructive sleep apnea, because with people with asthma, as their asthma severity increases, their lung function decreases. And as lung function decreases, less messages are sent to the upper airways to work. So nitric oxide is sterilizing the incoming air as it comes into the lungs. And nitric oxide is also a bronchodilator, so it's helping to open up the airways. So in essence, it's going to improve lung function. So if we're harnessing nitric oxide, it improves lung function. And by virtue of that, with a higher lung function, it should lead to less OSA. Or conversely, when lung function is low, OSA tends to be higher. That there seems to be a fairly significant feedback between asthma and OSA, and of course rhinitis here, because many people with asthma have rhinitis. Many people with rhinitis have sleep disorder breathing, including OSA. And many people with OSA, when we have asthma, it increases it 2 times or 3-fold.
Wow.
So where we look at this section here, because I think it ties in nicely with it, and then we'll discuss the importance of myofunctional therapy. And minute volume, how much air do we breathe? I think it's really important to consider this. How hard and fast, because again, it's coming back to the original definition of OSA. It's when a negative pressure caused during inspiration exceeds the dilating force of the airways, or the upper airways, to remain open. So we want these airways to remain open. But of course, how hard you breathe is going to influence the negative pressure. Normal breathing is 4 to 6 liters of air per minute. So it's about 10 to 12 breaths, and each breath is about a half a liter. When we look at this study here involving normal subjects, not people with OSA, so normal individuals, 20 to 28 years of age, and they have 5 liters of air during minute volume of 5 liters during nasal breathing, and just a little bit less than 5 liters per minute during predominant mouth breathing. But then when we look at people with obstructive sleep apnea, we've just seen that normal breathing is 4 to 6, and these individuals are breathing 15 liters of air per minute. And if they have overlap syndrome, which is obstructive sleep apnea and COPD, it's 12.8. So it's quite a significant increase in breathing. So if you're breathing 15 liters of air per minute, your respiratory rate is probably about 20 breaths per minute. And with each breath then it's going to be faster. So you're taking a breath every 3 seconds, breath in, breath out every 3 seconds, as opposed to a breath in, breath out maybe every 6 seconds. So the faster inspiration there is going to increase the negative pressure to remain open. And again, with asthma, 15 liters, quite similar to OSA. And bearing in mind such a link between asthma and OSA, we have to ask the question, what's going on here? Is it that minute ventilation is high in both groups, and that's contributing to the symptoms of both groups? So I think we're going to leave it at that for the moment. And in part 3, what we will do is look at factors related to flow, which will be a very nice tie-on from what we're talking about. So I'm going to pass you over to yourself, Marta, for your talk on myofunctional therapy.
Thank you, Patrick. Thank you for sharing such wonderful knowledge with us. And I just wanted to point out from a myofunctional therapy point of view that as myofunctional therapists, we find it critical to address mouth breathing, because we do see a lot of craniofacial changes that can lead to airway impingement if not addressed at an early age. And most myofunctional disorders may also be avoided if treated at an early stage. And some of the most common ones include the open mouth posture, mouth breathing, habitual mouth breathing. So it is essential for us to be able to establish that proper lip seal. And in order to do that, we have to do breathing re-education. So it is very, very nice to see how well butechial breathing and myofunctional work together and complement each other. So we do see a lot of excellent results with our patients, especially the ones that have sleep disordered breathing or any type of, just breathing problems like asthma. So thank you very much, Patrick. Very informative. Looking forward to part 3. And this is a very good treat for all of us.
Great. Thanks so much, Marta.
Thank you.